Good afternoon, everyone. Welcome to this webinar today on acute right ventricular failure in the ICU. And for that, we have Dr. Yanika Wolfe from Cooper University. And we are grateful for her to join us and share her experience and expertise with us. So whenever you're ready, Dr. Wolfe, please, you're welcome to begin.
Thank you for the warm welcome. So without further ado, today we're going to talk about the acute right ventricular failure in the critically ill. So again, my name is Yanika Wolfe. I'm one of the ICU physician at Cooper University Hospital in Camden, New Jersey. Today, my objectives with this talk is to, number one, understanding a normal RV anatomy and physiology. Then we're going to talk about what is a deranged RV physiology, followed by understanding some modalities to detect and monitor RV dysfunction. And lastly, coming up with an approach to the management of acute RV failure in the critically ill patients. And please feel free to stop me at any time if you have any questions or if it's not clear. Okay. This talk would be very participation heavy. So to get the most of it, let's have a lively participation. So let's start with a question. Question number one. Which of the following statement is true? The right ventricle does not accommodate an acute increase in preload well. B, the right ventricle does not accommodate an acute increase in afterload. C, perfusion of the right ventricle primarily occurs during diastole. Or D, the radial contraction is the primary movement of the right heart to expel blood out through the pulmonary valve. Anyone want to take a stab at this question? Sipten, am I allowed to call out people?
Yeah, I guess you can.
Awesome. Okay. So just randomly here, and I'm sorry if I pronounce your name incorrectly, but let's go with Tatu Risasi. John Callery on the chat says D, the radial contraction is the primary movement of the right ventricle to expel blood out through the pulmonary valve. So John is actually partially correct, and we'll go into this, but the answer to this question is actually B. So the right ventricle does not accommodate an acute increase in afterload well. So when we talked about the critically ill patient, most of us focus a little bit too much on the left ventricle. When we talked about cardiac output, mean arterial pressure, we talk about the afterload and preload of the left ventricle. This is because we kind of live in the left heart-centric world. And sometimes we kind of forget to appreciate that the right ventricle is a completely different system than the left heart. For a start, anatomically, the right ventricle wall is very thin. It's about 2-3 millimeters at the end of diastole, and it's very compliant. On the other hand, your LV free wall I hope the patient is okay. The LV free wall is thicker. It's approaching about 8 to 11 millimeters at the end of diastole, and it's very muscular compared to the right side. And the left ventricle is kind of shaped like a football. So the left ventricle pumps blood out by moving in a contracting motion, twisting, ringing motion, and some upward movement from the apex towards the base. Whereas the right ventricle, the primary movement of the right ventricle to expel blood out of the pulmonary valve is through the movement of the apex towards the base. It also has some twisting of the apex. And if you guys remember from anatomy class, there's this thing called the crista supraventricularis that pulls the right wall towards the septum, and that contracts the orifice of the tricuspid valve during systole. So again, right ventricle, thinner wall, less muscular. It's very sensitive to perfusion, whereas the left ventricle is being perfused only during the diastole. The right ventricle actually is being perfused during systole and diastole. And unlike the left ventricle afterload, which is a systemic vascular resistance, the afterload of the right ventricle is your pulmonary vascular resistance. And it does not adapt well to increase in afterload because although it has high capacitance, meaning that it can dilate and accommodate increase in preload or volume, it does not do well because of the thin wall. It does not do well when it has to face an increased afterload. Okay, so as mentioned before, the RV afterload is the pulmonary artery pressure or the pulmonary vascular resistance, which is, frankly speaking, it's very different than your SVR. It's a low pressure circuit, meaning that the pulmonary vascular resistance is only about 1/10 of your systemic vascular resistance. And the next slide is to illustrate that when the right ventricle has to face an increase in afterload from 10 to 30 millimeters mercury, you see how the stroke volume dropped precipitously from 100 to about 70%. And compare that to the left ventricle. The left ventricle can easily, with no problem, handle blood pressure, systolic blood pressure of 100 to like 140 millimeters mercury, with only about 10% drop in stroke volume. Additionally, look at this geometry. Here you can see how in acute RV failure, the right ventricle wall will become very dilated and becoming thinner, and it will balloon out. And look at the geometry. The geometry between the tricuspid and pulmonic valve becomes very distorted, whereas here, in the normal RV, you have a very beautiful geometrical setup between your tricuspid and pulmonic valve in expelling blood from the ventricle out to the pulmonary artery, whereas in your dilated, ballooning right ventricle, the geometrical arrangement is distorted. So that would affect the blood flow from your ventricle to the pulmonary artery, and essentially the movement of the apex towards the base of the right ventricle becomes less efficient in pumping out the blood. And then there's this thing called the interventricular dependence, which is a very important topic. So the right side of the heart and the left side of the heart really shares a space, a finite space, namely the pericardium. Because the pericardium is a finite space, when you have an increased volume or pressure on the right ventricle, the only way for the right ventricle to accommodate this is by pushing on that septum that it shares between the right ventricle and the left ventricle. So as you can see, the septum becomes a flat shape, and sometimes we call this a D-shaped left ventricle. Any questions so far? Okay, now that we understand what is a normal anatomy of the right ventricle and what happens when there is a deranged physiology of the right ventricle, let's move on to the next question. So question 2, which of the following findings support the suspicion of hemodynamic collapse due to right heart failure? A, the cardiac power output of greater than 0.6. B, a mitral annular plane systolic excursion of less than 1.7 centimeters. C, history of pulmonary hypertension with evidence of JVD, peripheral edema, and elevated liver enzymes. Or D, pulmonary pulsatility index of greater than 2. Oh, very good. Eugenie said C, history of pulmonary hypertension with evidence of JVD, peripheral edema, and elevated liver enzyme. And that's exactly the right answer. So with anything else, just like anything else in medicine, history and physical exam are very important. Let me get rid of this chat box. So on physical exam, when there's a right-sided failure, you might see JVD distension. You might see peripheral edema, and you might see splitting of the second heart sound or right ventricular heaves. Biomarkers elevations such as BNP and cardiac troponin can occur, but remember that they're not specific because it can happen also if you have left-sided failure. When you want to get a reliable measurement of the pulmonary hemodynamics, you can consider putting in a pulmonary artery catheterization. PAC, or also known as Swan-Ganz, can provide valuable information on your filling pressures of the RV and the LV, cardiac output, and pulmonary artery pressure. So essentially, it's a catheter that you can place into your SVC, going into your right atrium to get that right atrial pressure tracing or your CPP. And as you move towards your RV, you're going to have the tracing of the right ventricle pressure. And essentially, you will move on through your pulmonary artery to get the pulmonary artery pressure. And when you wedge the pulmonary artery catheter, you're going to get a measurement or an estimation of your LA, your left atrium filling pressure. Some of the hemodynamic parameters that could be useful in detecting RV failure includes the right atrial pressure and wedge ratio. So it's pretty straightforward. You get your right atrial pressure or your CPP, and if you know your wedge pressure, you can get a ratio of it. A ratio of greater than 0.5 to 0.8 usually is associated with RV dysfunction. So it makes sense if your right atrial pressure is getting closer to your left atrial pressure, that should clue you into the evidence of possible right-sided failure. And then another one is a pulmonary artery pressure index. This is the pulmonary artery pulse pressure. This measurement gives us an idea of the ability of your RV to generate stroke volume. So the way to get your PAPI, or pulmonary artery pulsatility index, is to know your PA systolic pressure minus your PA diastolic pressure divided by your RA pressure. And really, usually PAPI of less than 1 is associated with RV failure. And specifically in acute inferior MI, with right-sided failure, a PAPI of less than 1 is predictive of mortality and the need to institute mechanical circulatory support. And of course, point of care echo can be a good way, a non-invasive way to detect evidence of right-sided failure. So this is a personal long axis view where you can see the proximal RVOT, your left ventricle, your LVOT right here, and your left atrium. And this is called the Three Musketeers sign. Essentially, in normal RV, the three chambers, your RVOT, your LVOT, and your left atrium should be about a third of the screen. So 1/3, 1/3, 1/3. But notice here on this clip, the right ventricular outflow tract is somewhat bigger or larger in measurement compared to the other two chambers. So this should clue you into maybe there is some evidence of RV dilatation or RV dysfunction. We all know D sign on the personal short axis. Again, the flattening of the septum, this is an evidence of intraventricular dependence, whereas increase in volume or pressure on the right ventricle can cause flattening of the septum, causing that D-shaped appearance of the LV because of interventricular dependence. And then RV free wall thickness that we can measure through subxiphoid area can also clue you into whether there is an RV hypertrophy for free wall measurement of greater than 5 millimeters. Usually you see this in chronic pulmonary hypertension where the RV has seen a lot of elevated pressure that it has to work against. And this is the money shot, the apical 4 chambers. This is the right side of the ventricle, left side of the ventricle. And you can use your MO to measure TAPSE, which is your tricuspid annular plane systolic excursion. And really, this is measuring how well the RV is moving from apex to base, which is the primary motion of the right ventricle to expel blood out into the pulmonary artery. TAPSE, or tricuspid annular plane systolic excursion, normal value is about 2.4 to 2.7 centimeters. Anything less than 1.7 centimeters is usually associated with RV failure. And we can even go fancy, and we can quantitatively estimate PA systolic pressure using a non-invasive measures of point of care echocardiography. So as long as there's no obstruction between your right ventricle and your PA, your pulmonary artery, your RV systolic pressure should equal your PA systolic pressure. And how do you estimate this? First, you got to get a apical 4 chambers view. You can put your collar Doppler on and detect any evidence of tricuspid regurgitation. Then you can use your continuous wave Doppler to measure the velocity, the maximal velocity of that TR jet using Bernoulli's equation, which is the simplified Bernoulli's equation is simple. It's just 4v squared. So if you know the velocity of the jet, which is here is about 4.19 meter per second or 419 centimeters per second, and you can plug it into the equation, the Bernoulli's equations, 4 times v squared. V squared here is going to be 4.2. You round this up to get 17.6. You multiply that by 4. You're going to get the pressure gradient between the right ventricle and the right atrium. And if you add your RAP, your right atrial pressure, to this tricuspid pressure gradient, you will get your estimated RVSP, or again, if there's no obstruction between your RV and your pulmonary artery, your RVSP is just going to be the same as your PASP. Okay, let's do some cases. Let's do some doctoring. Before we move on to the cases, any questions so far about detecting RF dysfunction, measurement using non-invasive versus invasive?
If I could ask Dr. Wolf,
Sure.
how soon would you be able to see these changes after an acute insult?
Yeah, so it really depends. It's a very good question. So in acute changes, so remember your right ventricle is unlike your LV, right? It's not muscular. It can't really generate high pressure. So if you suspect that there is some failure of right-sided failure from increased PA pressure, your RVSP would not be high if this is purely an acute event. So, for example, if you have an acute PE with otherwise normal right ventricle, no evidence of pulmonary hypertension in the past, your right ventricular systolic pressure will not be as high as if you have someone with chronic pulmonary hypertension and the RV, in a sense, has already gotten used to higher pressure environment. So in that kind of cases, your right ventricle will be able to generate higher right-sided systolic pressure. In terms of the dilatation or the dysfunction itself, you can quickly detect that on either point of care ultrasound or you can detect that quickly. So as soon as there's an insult, usually when the RV is no longer able to compensate, you'll see the dilatation and you will see the dysfunction. There's a questions on the chat box. What are the precipitating factors for acute right-sided failure? That's a very good question. So there are plenty, and we'll illustrate some of this through the cases, all right? So case number 1, we have a 44-year-old male with hypertension, had a spinal surgery 1 month ago, came in with dyspnea for 3 days and found to have acute PE, settled PE. He was tachycardic. He was a little bit hypotensive, blood pressure 102/95, tachypnic respiratory rate of 24, and hypoxic 88% on room air. You grab an ultrasound that shows right-sided dysfunction, dilated right ventricle, right atrium, and pulmonary artery with the right heart cath measurement of CVP of 15 and PA pressure of 50/18. So this is your case 1, acute right-sided failure because of the PE that's sitting in room 1. And then it's one of those nights where you have like multiple sick patients at once. So you move on to bed 2, you got called, there's another patient in bed 2, and this time we have a 61-year-old female with hyperlipidemia, active smoker, came in with sudden onset chest pain, diaphoretic, clammy, cold to touch. Here are the vital signs. And what do you guys think about this EKG? I need a volunteer. I need a brave soul to interpret this EKG. Inferior STEMI, very good. Yeah, exactly, right? It's very obvious you have 2, 3 AVF elevation and concomitant ST depression, certainly concerning with this clinical condition of inferior STEMI. So this patient got brought to the cardiac cath lab and they found a complete RCA occlusion, which was stented, and then she was brought back to the ICU. And then you get another phone call from your nursing colleague that you have another sick patient in room 3. This one, you have a 35-year-old female with sickle cell disease who has pulmonary hypertension and initially was admitted for presumed vaso-occlusive crisis, for which she was treated with copious fluid resuscitation. The nurse called you because she knew that she had developed tachycardia, progressive hypoxia, and the blood pressure had become really low. Here's the chest x-ray. What do you all think about this one? Right off the bat, I noticed the big heart, right? It's very prominent. Certainly some cardiomegaly. And then also definitely pulmonary edema. And your EKG, nothing jumping out. The ST changes, there's no significant ST changes for acute ischemia or infarction. It just looks fast. So, couple of blood works, a lot of red. That's the one thing that I noticed here. Elevated liver enzymes, lactic acid had went up from 3 to 11, some coagulopathy, leukocytosis, and this creatinine bump is actually new. So very concerning for an organ hypoperfusion for sure. On echo, you see some pericardial effusion right here. You look at this echo, it's not really moving that well. So certainly very concerning. The RV also look bigger compared to the LVOT and the left atrium. So wondering if there is any RV dysfunction as well. A little bit flattened on this personal short axis view. And again, illustrating dilated RV with not so great of a LV movement right there. So they read the echo as a moderately enlarged right ventricle with severely reduced systolic function and severe pulmonary hypertension with elevated PA systolic pressure estimated to be around 60 to 65 millimeters mercury. Very prominent. So you can tell right off the bat there must be some chronic component to this, because if this is all acute, your right side usually cannot generate this high of a pressure. All right, so a lot of sick patients, and there's only one you, and so many sick patients, you gotta have an approach to managing the sick patient. In the management of acute right-sided failure and critically ill, I like to think of the process about what's going on, what's wrong, and really categorize it into 3 buckets. One is assessing the pump. How is the heart itself? Is there any evidence of poor contractility? And then I like to look at the tank. Do I have a suboptimal preload? Is it too low? Is it too high? Am I hypovolemic? Am I hypervolemic and congested? And then I take a look at the pipes. Is there any problem with excessive afterload? Because remember how RV is very different than your left ventricle, right? Your right ventricle cannot really handle acute increase in afterload. So again, putting it into 3 different buckets, is the pump the problem? Do I have poor contractility? What about my tank? Do I have suboptimal preload? And what about the pipes? Do I have a problem with excessive afterload? So let's talk about optimizing preload. Often I hear from trainees that, Dr. Wolfe, I was told that with any RV failure, I need to make sure that the volume is up high. Well, my response to that is that it really depends on the clinical condition. So you gotta know whether your right side ventricle that's failing is facing a normal or increased RV afterload, because the management is completely different. And once you try to optimize your preload, they would ask me, what do you usually follow? Do you follow mixed venous target? Do you follow your CPP? Do you leave your Swan-Ganz in place? Me personally, I would try to optimize my preload using a couple of modalities. I like to follow my mixed venous. I like to target it between 70 to 80%. And I like to follow the trend of CPP. The absolute number itself is not quite important, and truly it depends. If it depends on the clinical scenario. If you have someone with acute myocardial infarction, right, that is a preload dependent state, I would try to get an optimized preload without over um, resuscitating them. But I would follow my CPP. I would make it around 10 to 12. But if I have someone with congested right-sided failure from chronic pulmonary hypertension with pulmonary edema, I would like to diurese, and I would really bring down that CPP to about 8 to 12. And some people would argue that you can consider leaving your PA catheter in place for serial measurement or serial management, but some pulmonary hypertension specialists would also argue that there's really not much benefit of leaving your PA catheter in place as long as you can follow your mixed venous or your central venous pressure trend. So let's go back to our case. This is our acute pulmonary embolism case with a right heart cath of CPP of 16 and PA pressure of 50 over 18. What do you guys think about this PA pressure? High, low, normal, impressive, non-impressive, concerning, non-concerning? Yeah, I would say it's on the higher side, right? Your PA systolic pressure is definitely on the higher side. Agree. High and concerning. I would agree with y'all. So 50 over 18 and CPP on the higher side. And then you put your echo on and you noted this D shape, the ventricle. Remember what we said about interventricular dependence, right? Increased pressure and volume on the right ventricle can push over the septum, flattening the left ventricle and giving you low cardiac output because really there is not much space for the LV to expand and fill during diastole. So, in fact, in cases like this, you might consider diuresis to improve interventricular dependence problem. Now, differently in this case with the acute MI, sometimes you might want to do fluid resuscitation, but be gentle. You don't want to over resuscitate this kind of patients with fluid because as you extend the right ventricle, remember how the right ventricle loves being perfused during systole and diastole? Now, as you dilate that right ventricle, you're going to increase the transmural pressure. When there is an increased transmural pressure, then it would affect the coronary perfusion. So gentle fluid resuscitation, you do not want to have a big dilated RV in this kind of cases. Yes, you do want to have an optimized preload, but certainly you want to keep that right ventricle non-dilated so that you don't have increase in transmural pressure affecting your coronary perfusion to the right side. And then our last case, right, the 35-year-old with sickle cell pulmonary hypertension who received a lot of fluid and then become progressively hypoxic and hypotension. And take a look at this chest x-ray, how it's very evidence of pulmonary edema. In this kind of cases, you truly want to optimize the preload by considering diuresis and taking off some of those congested fluid so that you can, again, relieve the effect of interventricular dependence by decongesting the right ventricle. Right. Any questions about preload so far? Very good. Then we'll move on. So now that we talked about the preload or the tank, then we can move on and talked about afterload. So how do we fix afterload? Really, the most important thing is to pay attention to your underlying hypoxia, hypercarbia, and acidosis, because these three factors can certainly affect your pulmonary vascular resistance. And this figure right here is to illustrate that as you go from pH of 7.4 to 7.1, look at how fast that PVR is increasing. It's very impressive. So fixing the underlying hypoxia, hypercarbia, and acidosis can certainly help with your afterload and manage your pulmonary vascular resistance. Now, you can consider using some agent that could reverse the pulmonary hypertension itself. There are some drugs that target the cellular pathways that has been implicated in the pathophysiology of pulmonary arterial hypertension. But be mindful that none of this medication has been approved or has been studied extensively in the treatment of RV failure in the critically ill patients. So you also need to be very careful because each medication that is pulmonary vasodilators can have a systemic vasorelaxant properties as well, causing hypotension. So in patient with RV failure and in shock, you have to be very careful in administrating this pulmonary vasodilator agent. I think for us in the ICU, the two drugs that we use the most is usually a epoprostenol, which is a prostacyclin, and nitric oxide, which is a soluble guanylate cyclase stimulators. Usually I give them through inhalation to minimize the systemic vasodilation properties. Inhaled nitric oxide is a very potent pulmonary vasodilation. It has rapid onset of action, and it also has extremely short half-life, which makes it an ideal agent for unloading your RV in the ICU. Epoprostenol, which is a prostacyclin derivative, has been successfully used in managing patients with RV failure, especially in the cohort of cardiac surgery patients. So, how do you fix afterload? What about in the case of the acute pulmonary embolism? Certainly you have an obstruction issues, right? So to fix the underlying issues, you can consider thrombolytics, you can consider catheter-directed therapy, or you can consider mechanical thrombectomy, lysis thrombectomy, very good. Yep, and what about in the case of acute inferior MI RV failure? How do we want to fix the afterload here? Or rather, the question is, is there an afterload problem in acute inferior MI with RV failure? Yeah, as the name suggests, right? Acute inferior MI, there's a problem with the pump. There's not really an afterload problem per se. So in this case, we probably shouldn't be worried too much about fixing any afterload and focus on fixing the pump itself. And then lastly, what about the case of acute on chronic pulmonary hypertension with RV failure? how do we want to fix the afterload right here? The basic tenet is to make sure that you fix the hypoxia, hypercarbia, and acidosis, which is very important because any of those factors can certainly increase your PA systolic pressure and worsen your pulmonary hypertension. But also, it's important to pay attention to what is the actual cause of the pulmonary hypertension, right? So we have 5 different groups of pulmonary hypertension according to WHO classification. Is this group 1, which is a primary PA hypertension, or is it group 2? Is it because of the left side failure? Or is it group 3? Is there any evidence of severe COPD, emphysema, any lung issues that cause pulmonary hypertension? Or is it group 4? Is it one of your CTEPH, your chronic thromboembolic pulmonary hypertension? Or is it group 5, things like scleroderma, stuff like that? So focusing on what is actually the underlying issues of the chronic pulmonary hypertension, but really in acute on chronic pulmonary hypertension cases with RP failure, I think it will be very useful to focus on the acute exacerbation factors, which usually is either, hypoxia, new onset hypercarbia, or acidosis. And once you make sure that you take care of those 3, usually that would place you on a better place than at least back to the baseline chronic pulmonary hypertension state. All right. And then lastly, let's talk about insufficient contractility. So this is a problem where the pump is not functioning well, right? In this kind of cases, it is very, very important to maintain coronary artery perfusion and be very careful in using drugs that increase myocardial contractility. Because the analogy is that, if you have a horse that are already very tired and you keep whipping it and making it work faster and harder, eventually that horse is going to give up and die. So just like your heart muscles, your myocardium, if you already have a diseased myocardium, the best thing is to unload it and to let it rest so that it can heal itself. So be very mindful in using inotropic agents because you may exacerbate the problem. And lastly, be very careful with fluid resuscitation because, again, if you overload that right side, although it's very high capacitance systems, meaning that it would accommodate the increase in your preload and it would just balloon up and dilate it up. But the problem is that you will increase RV wall tension, which in turn decrease your coronary artery perfusion, which then in turn worsening the function of your myocardium. And then it just becomes a circular problem. And finally, you'll get into the spiral death of right ventricle, which is not a situation where you want to be at. Okay, so in terms of defending the coronary perfusion, it's very important to maintain your MAP, your mean arterial pressure, right? Because remember, the right ventricle is being perfused during systole and diastole. So not only you need to have a good systolic blood pressure, you also have to have an acceptable diastolic blood pressure to maintain your coronary perfusion. There's been no study to show whether any of the vasopressors agent is better compared to any of them in the management of RV failure. One consideration is that vasopressin does have a pulmonary vasodilation property. So sometimes people prefer to use vasopressin because of the theoretical pulmonary vasodilatation property. And then lastly, let's talk about inotropes. You can consider using inotropic agents, but be very mindful because either of them, milrinone and dobutamine, which are very commonly used in the ICU setting, both of them can cause a drop in your systemic vascular resistance, resulting in worsening systemic hypotension. So milrinone is your phosphodiesterase 3 inhibitor. It does have inotropic properties, and on top of that, pulmonary vasodilation. Usually, milrinone is the agent of choice if you have pulmonary hypertension with biventricular failure. And then dobutamine, be very careful if you use dobutamine, the risk of arrhythmia. And of course, if you have someone with acute kidney injuries, kidney dysfunction, your milrinone will stay in the system for longer than if you don't have any acute kidney dysfunction. And lastly, right, we talked about how the myocardium that are injured should be rested. And this is where mechanical circulatory support device comes into play. What are your options? So there are several. If you do have both right side and left side failure, you might want to consider VA ECMO support. If you only have isolated right-sided failure, you can consider a couple of mechanical circulatory support, such as Impella, right side Impella or Impella RP. You can also consider tandem heart, which is a cannulation of your right atrium. You make a transeptal puncture and have that cannula over to the pulmonary artery. Or you can also use a right-sided temporary ECMO, or this is the PPA ECMO, the right-sided temporary ECMO, where you would cannulate your SVC and the cannula will go through your right atrium, the right ventricle, and then will end up in the pulmonary artery. So to summarize, we learn about normal right ventricle anatomy and physiology and how right side ventricle is completely a different system compared to your left side. And we talked about what happens in deranged right side right ventricle physiology. And we touched briefly upon modalities, invasive and non-invasive, to detect and monitor right side dysfunction. And lastly, we came up with an approach to management of acute RV failure. And again, I like to keep it simple. When you have an RV failure, take a look at the tank, the pump, and the pipes, right? Is it a problem with the preload? Is it a problem with afterload? Or is it the problem with the pump or the heart itself? Or you have like all three problems. So again, RV, super different than LV. And if you keep it simple, I think you'll be able to take care of your sickest of the sick patients with RV failure. And I think that's all I got for you.
Thank you, Dr. Wolfe, for that amazing talk and taking us through the anatomy, the physiology, and also giving us a very practical approach on how to approach these patients with right ventricular failure. So it's time for questions and comments. If anyone has any, you can unmute yourself or you can write in the chat.
Dr. Wolfe, this is Nathan. Thank you for the top tier talk as usual. Can I ask you, when you're first using a lot of point of care ultrasound, you'll end up using it during a cardiac arrest, and a lot of times you'll see the RV blown out. And, sometimes there's a temptation to give thrombolytics, saying that the patient died of acute PE. But can you talk about that? Where with the deranged physiology, the RV blowing out, how can you tell between chronic RV dysfunction versus acute RV dysfunction? Tips on echo. And if you said that during the talk, maybe I missed it. And then also go further into cardiac arrest, and when you give lytics or not, and how does ultrasound help you in that situation, or hurt you?
Yeah, wonderful questions. So, as we said, right, any derangement of hypoxia, hypercarbia, acidosis, which really in any cardiac arrest, we will see all three most of the time, can cause RV dysfunction. So when you do use your cardiac point of care echo to take a look at your heart, and you see a dilated heart, I think if the clinical history fits, and again, going back to, basic, right? Findings on ultrasound, you cannot use by itself. You need to consider the whole picture. If the clinical story fits, if this is a 55-year-old with history of metastatic cancer, and has had prior DPT in the past, cardiac arrest, PA arrest with evidence of dilated RV. And then on top of that, you also have the option to take a look with your probe to see if there is any DPT, right? So if you have a finding of DPT, you have the clinical story that fits, and you want to give TPA, I think clinically that is the right move to do, the right step to do. But again, understanding that in a lot of cardiac arrest cases, really, you will see dilated RV. So you can't use that finding alone by itself to conclude that, this would warrant giving lytic therapy. And then the other question, your other question was about point of care ultrasound in cardiac arrest in general.
No, but also, how do you tell RV on ultrasound that is chronically diseased versus one that is acutely?
Yeah, very good question. So again, RV is usually a thin walled structure, right? So it doesn't work out a lot, unlike the left ventricle. And if you have a chronic condition like chronic pulmonary hypertension causing a big RV, you're gonna see a thick free wall on the RV. And as I said earlier, if you can get a good subxiphoid view and you measure your right ventricular free wall, anything greater than 5 millimeters usually will clue you into the evidence of chronic pulmonary hypertension problem. I'm trying to find it. And then a second clue is that because you're right, we talked about how right ventricle is not a structure that can handle acute increase in pressure, right? It doesn't really generate high pressure when things are happening acutely. So this is why some quantitative measurement can be helpful. So if you measure your RV systolic pressure estimated and it happens to be 70 millimeters mercury, there has to be some chronic component going on. Because if this is just purely acute changes, your right ventricle would not be able to create that kind of pressure. If this is purely an acute pulmonary embolism causing right side failure, usually sometimes you wouldn't even see an elevated right-sided pressure. So your RVSP could be 35, maybe 40 maximum, but usually doesn't go above 60 millimeters mercury. And there is a question on the chat. Perhaps this might not be the right forum, but can you shed light on this observation? Many at times I've seen patients in the ICU with sepsis and septic shock are placed on both pressors and inotropes to help with maintaining blood pressure. And what is your take at this practice? So what I would say to that is that sometimes you might need both, and this is why using your point of care ultrasound can help. Because if you don't see, so someone with septic shock certainly has distributive etiology, but there is nothing that's stopping them from having cardiac shock as well. So patients can have as many different type of shocks as they want. They can have distributive shocks, they can have obstructive shock, they can have cardiogenic shocks, they can have all of them at once if they want to, right? And that's why I think using an ultrasound to help determine whether there is any cardiogenic component to this could be helpful. Now, in terms of using inotropes, you got to be careful. It might be helpful in the beginning. Again, the analogy of if you have a horse that's already tired and you keep making the horse work hard, eventually it will just give up. So be very careful. If you think truly that there isn't a component of septic cardiomyopathy, be very careful. If you decide to use inotropic agent, be very careful that you don't overuse your myocardium. I hope that helps answer the questions.
Thank you. Anybody else with any questions or comments? Okay, if no more questions, then I think we can end here. Thank you, Dr. Wolfe, for taking the time out to give us this talk, very important talk about right heart failure in the ICU. I'm sure everyone has benefited from this, and we hope to see everyone again for the next webinar, which will be on kidney failure in the ICU. So we'll move from the heart to the kidneys in the next webinar. We hope to see you all there. Thank you all and have a good day.
Awesome. Thank you, guys.